Hello, my name is Dr. April Armstrong. I am Professor of Dermatology and Associate Dean for Clinical Research at the University of Southern California. And today I talked about what's new in JAMA Dermatology. Now, first of all, I want to thank everyone for your readership for JAMA Dermatology, and I'm proud to be one of the editorial board members for JAMA Derm. So they're having a lot of great articles that have been published, so it's a little difficult for me when I selected the different articles for this talk. I wanted to highlight some clinical pearls that were published in the journal, and hopefully you can try in your clinical practice. We know that verruca plana, whether it occurs on the face or on the back of our hands, can be quite difficult to treat. So there were some successful reports of clinicians who has tried to mix topical vitamin D, so for example, calcipotriol ointment, with 5-fluorouracil in 1-to-1 ratio, mixing that together and applying it to verruca plana for a few days. And then what was found in these reports is that after you only apply it for a few days, but then after about 12 weeks of observation, they see a significant improvement in terms of the disappearance of verruca plana. So hopefully that's a tip that we can try in our clinical practice. And another thing that was published that caught my interest was a systematic review that was done, and also a network meta-analysis comparing the different therapies for male pattern baldness. Now, what was seen in this particular systematic review when they looked at minoxidil and 5-alpha reductase inhibitors was that in the following ranking order were the top 3 most effective treatments. First, they found that dutasteride at 0.5 milligrams to be highly effective. Following that is finasteride at 5 milligrams. And then following that is minoxidil 5%. So hopefully that will pique your interest and take a look at this particular systematic review a little bit closer to look at all the different therapeutic options that were reviewed and how they ranked relative to another. And the third part that I spoke about was about the off-label use of our JAK inhibitors. And specifically, there were reports of upadacitinib being used, for example, in severe oral erosive lichen planus. And what was found is that 15 milligrams of upadacitinib can be quite helpful in some patients suffering from this disease. And finally, for baricitinib, which we know is approved for alopecia areata, in case reports that when you use baricitinib off-label in some patients who had livedoid vasculopathy or severe lichen planus, it has shown efficacy in that particular patient population. So something to consider potentially as an off-label use for baricitinib. Thank you for your attention.